Then, so hi everyone, my name's Anisha and I'm one of the fifth years that will be presenting this morning. So we're going to go over pediatric cardiology. So we'll cover some of the main topics from your matrix as well as hopefully some multiple choice questions as well. So cardio questions will very likely turn up on your written exam and could also be OSCE stations. So I think in the past we had like a VSD presenting as failure to thrive. So just good to know as well, even just for OSCEs as well. So I'd take some time to understand some of the main conditions, especially the R1s, and know all of the buzzwords. As I'm sure you guys know, the Paeds faculty just loves buzzwords. So we'll go through some of the buzzwords that you guys can remember as well. Okay, so I think firstly, it's really important that we try to understand the fetal physiology and some of the circulatory changes that happen at birth, as that gives us a better understanding of some of the congenital heart diseases and the different ways they present. So fetal circulation is quite different from adult circulation. And as the fetus doesn't use its lungs, so it doesn't need to, it relies on the placenta for oxygen and on three main shunts to keep oxygenated blood within the systemic circulation of the baby. So oxygenated blood from the placenta flows through the umbilical vein. So vein as it's coming back to the heart, the baby's heart, traveling through the ductus venosum to bypass hepatic circulation, so straight into the IVC and then into the right atrium. So to prevent all of this oxygenated blood from going into the pulmonary arteries or the lungs, where it's essentially just dead space at this point, the foramen ovale between the left and the right atrium shunts some of this blood from left to right into the left atrium, where it then can go into the systemic circulation via the aorta. Some blood, however, will inevitably travel through the pulmonary artery, and that's why we have the ductus arteriosus there, and that aims to shunt this oxygenated blood straight into the aorta. So again, it can go into the systemic circulation. So at birth, there are some really important changes that happen to close these shunts and allow for normal adult circulation to commence. So as the baby takes its first breath, the resistance to pulmonary blood flow drops and the volume of blood in the lung rises. So that causes increased left atrial pressure. On the other hand, right atrial pressure actually drops because there's less volume, there's less blood returning to the right heart, as the placenta isn't a part of the circulation anymore after birth, after it's been clamped off. And this now creates a left to right shunt, which will close the foramen ovale. So back to normal, in most cases, adult circulation. So the ductus arteriosus normally closes within the first few hours or days of life due to low pulmonary venous resistance, as well as lower prostaglandin levels. But there are some babies that have ductal dependent congenital heart diseases, and this will be the time where they will deteriorate. So the time where the ductus arteriosus is physiologically closing, that can be when they present with more severe symptoms, but we'll discuss this a bit more later. So the ductus arteriosus should close around this time, and if it doesn't, then it would be classified as a PDA or a patent ductus arteriosus, but again, we'll discuss that more later. Okay. So we'll start by looking at all the different types of congenital heart disease. So they can be classified into acyanotic and cyanotic heart disease. So this is a handy memory tool that some people use to remember which belong to which group. So there's the 5 Ds and the 5 Ts. So with the 5 Ds, the acyanotic heart disease is much more common, but cyanotic heart diseases are generally more serious and they can require earlier intervention. Acyanotic heart diseases are more common. There's a lot more conditions on your matrix. I've bolded the ones that we need to know in more detail. So there's ASDs, VSDs, PDA, as well as coarctation of the aorta. And with the cyanotic heart diseases, there are very many, but the main ones the faculty wants us to focus on are tetralogy of Fallot, as well as transposition of the great vessels. It's good to know the other conditions, because there are a lot of congenital heart diseases we could talk about, but for the sake of time, we'll probably only discuss the ones that are on your matrix, because you will need to know them in the most detail. I would take some time as well just to get to know some of the other congenital heart diseases and what the general anatomic defects are, but focusing on the ones in bold would be important. Okay, so we'll start with the tetralogy of Fallot. So it's the most common cause of cyanotic heart disease and is associated with some genetic conditions. So Down syndrome or DiGeorge syndrome, which is also known as 22q11 deletion syndrome. It's also associated with some maternal risk factors, such as a family history or like a predisposition to tetralogy, maternal diabetes or alcohol use, or rubella infection. So I guess we're thinking about toxins during pregnancy that could have affected like fetal embryonic development. So tetralogy consists of 4 main anatomical features. So a large VSD, and an aorta that overrides this defect in the ventricular septum. It also involves subpulmonary stenosis, so that's narrowing just below the pulmonary valve, and that causes right ventricular outflow tract obstruction. So it's mostly just referred to as RVOT, or just focusing on the ventricular outflow obstruction, but it is usually due to the subpulmonary stenosis, as well as right ventricular hypertrophy as a result of this obstruction, as the right ventricle needs to work a lot harder to pump blood through this smaller lumen. So the extent of the right ventricular outflow obstruction determines how sick the baby will be. So if there's very significant obstruction, the baby could be cyanotic and unwell quite early on. But in most cases, these babies generally aren't cyanotic at birth and will more likely present with TET spells. So these classic episodes we'll discuss in a second at around 2 to 4 months of life. So these spells can occur when the baby is crying, feeding, or defecating. So essentially just really stressful events where there are increased oxygen requirements, and they can present just very blue. So they were short of breath and hypoxic in that acute episode. And this generally resolves when the stressful event is over and they have time to rest. But in some cases, it can be prolonged. And this is a life-threatening event. So it does require urgent treatment in the hospital if it goes longer, but we'll discuss that on the next slide. So another buzzword you'll see often in exam questions is a child who often is seen squatting by their parents when they're exercising or like playing with their friends, and they're just a bit more, I guess, with stressful activities. So kids with tetralogy of Fallot will instinctively squat when their oxygen requirements are not met, as squatting kinks the femoral arteries, which will then increase systemic vascular resistance and also will increase left heart pressure. So this will aim to reduce the right to left shunt and aim to restore like there's more oxygen within the systemic circulation. So this is a common description we see in exam questions and in textbooks. I think in reality, it's quite rare to see a baby present at this stage in Australia, because in most developed countries, we screen for tetralogy antenatally, or like it's usually picked up quite early in life. But unfortunately, it could be missed and they can present with TET spells and the squatting and exercise. So it's important to know how to pick it up, as it is quite life-threatening. And the murmur heard is a harsh ejection systolic murmur, which does make sense as there is subpulmonary stenosis, and we know that pulmonary stenosis presents with an ejection systolic murmur. Okay, so as I said, most cases, well, in Australia at least, are diagnosed antenatally or after a murmur was identified, usually within the first few months of life in like neonatal exams and baby checks. But however, babies can still present symptomatically, as we talked about. So one of the important tests that they do in hospital is a hyperoxia, or also known as a nitrogen washout test. So this test is used to identify cyanotic heart disease and distinguish it from pulmonary causes of neonatal hypoxia. So the infant is placed in 100% oxygen for 10 minutes, and looking at the blood gas, if their arterial concentration of oxygen remains low, the diagnosis of cyanotic heart disease can be made. But if the oxygen improves, it is not cyanotic heart disease, it's likely a pulmonary cause of the hypoxia, because it could be corrected with oxygen. So these babies won't be able to, their hypoxia won't be corrected once they've been given oxygen. ECG and echoes can also be useful. ECGs can show right axis deviation and right ventricular hypertrophy. But one of the big buzzwords is the chest X-ray findings, which can show a boot-shaped heart. So it's a classic buzzword, but it's also helpful to know why it's boot-shaped in the first place. So it's boot-shaped because of a few reasons. So there's decreased pulmonary vasculature markings, as well as a gap or an area where the pulmonary artery segment should be, but it's not visible in this case. So it gives it that curved appearance. And with the apex also points upwards because of the, well, depending on the severity of the right ventricular hypertrophy. So that's also why it looks like a boot from the bottom end as well. So in terms of management, TET spells are usually self-limiting and followed by a period of sleep, or the child just needing to rest and calm down after that moment. But if it goes for longer than 15 minutes, they do require prompt treatment with oxygen, sedation, and pain relief if possible. And if all those initial steps don't work, you can also assist if it's a young baby, put their knees to chest, thinking about like the purpose of squatting is to increase their systemic vascular resistance. They can try those measures too. If that isn't working, they can also consider IV propranolol, which acts as a peripheral vasoconstrictor and also to relieve some of the pulmonary muscular obstruction. So definitive management, it will be with most of these congenital heart diseases, is surgical repair, usually within the first year of life, to close the VSD as well as relieve the right ventricular outflow obstruction. So children with really severe RVOT and cyanosis in the neonatal period may require earlier intervention even before surgery can be had. So if they're quite young, they may need a temporary shunt put in just to increase the pulmonary blood flow before they can have this final definitive surgery. Okay, so we'll move on now to our first multiple choice question. So we have here a 2-day-old baby, cyanotic baby, with no evidence of respiratory pathology on chest x-ray, and on auscultation, there was no murmur to be heard. What do you guys think is the most likely congenital heart disease responsible for this presentation? So we've got a few people messaging in the chat. I'll give everyone a moment. Okay, amazing. Everyone said O, which is correct. The transposition of the great vessels. So really classic exam question. I've just underlined some of the buzzwords in the question that let us know this is transposition of the great vessels. So firstly, cyanotic baby, we already know what category of heart diseases we're looking at. And presenting at 2 days old is a common time frame for transposition of the great vessels, because we're thinking about at around 2 days old, that's usually when the ductus arteriosus physiologically closes. So this is a time where there's suddenly a drop in oxygen distribution around the body. So that's a common time to present, as well as no murmur heard, which is classic for TGA. Okay, so TGA is the anatomical reversal of the great vessels. So the aorta is actually connected to the right ventricle and the pulmonary artery is connected to the left ventricle. So it's often considered to be one of the most important cyanotic heart diseases, as it needs to be managed like as soon as possible. So because there is this reversal of the great arteries, deoxygenated blood is returned to the body and oxygenated blood remains in the pulmonary circulation. So essentially there are 2 parallel circulations, and the only way for these babies to survive is if there's another defect, such as a PDA or an ASD or VSD, that allows for mixing of the blood between these 2 circulations. So usually there will be some other defect associated with it. So it presents on day 1 to 2 of life, usually when the ductus arteriosus closes normally, and there is suddenly a lack of oxygenated supply making its way into the systemic circulation, and they can present quite suddenly after birth, even though they were well in the first few days of life. So usually no murmur is heard, unless there is something like a VSD present, which you could hear like the murmur component of the VSD, but usually the buzzword is just a lack of murmur, that this is actually TGA, as most other congenital heart diseases will have an associated murmur. It can be confusing because we're thinking of like respiratory versus cardiac causes, but I think usually they'll let you know in the question that there aren't any respiratory findings on chest x-ray or things like that that will help us rule it out. So another buzzword is the egg on string chest x-ray appearance. So a good way to remember it is that TGA has the letter G in it, and egg also has the letter G in it. So just a warning, I put a lot of like really silly memory tools in this slideshow, but I found them helpful. So I just put them in there just in case anyone else likes them. So the reason it looks like an egg is because of cardiomegaly. So it's a really large globular heart that just looks like a giant egg sitting in the chest. And the reason it's on a string is because there's stress-induced thymic atrophy. So it has quite a narrow mediastinal appearance. So that's why it looks like it's on a narrow string. So in terms of management, all babies will need prostaglandin infusions. So the prostaglandins will keep the ductus arteriosus patent and allow for mixing of the blood before they can get surgical intervention that they will need eventually. So if the prostaglandin infusion isn't working, or if surgery needs to be delayed for some reason, some babies will require an emergency balloon atrial septostomy, which basically is just the creation of an ASD via cardiac catheterization. So just allowing for that mixing like ASAP. So all babies will eventually require an arterial switch surgical procedure within the first few days of life that switches over the great vessels. And during this procedure, coronary arteries are also transferred over to the new aorta, which is important to know. Okay, so we'll go on to our second multiple choice question. So we have an acyanotic 3-month-old infant with poor weight gain, poor feeding, tachypnea, and a loud pansystolic murmur. Give you guys a moment in the chat what you think the most likely diagnosis is. Okay, amazing. We've got a bunch of S's in the chat. Okay, so we'll go through with a few different answers actually. So the most common answer was S, which is the right answer. So we'll go through why that is. There's also a few K's in the chat as well. So we'll talk about that in a second. So, so this was an acyanotic infant. So we know which category of heart diseases we're looking at. And they presented with poor weight gain, poor feeding, sort of a failure to thrive picture. And they have a loud pan-systolic murmur. So failure to thrive is quite a non-specific symptom. It can present with a lot of congenital heart diseases. It is very associated with VSDs presenting at around this time frame, but it's that murmur that tells us which heart disease this is. So with a PDA, this is unlikely to present with this particular murmur, so that's why it's less likely on our differential list. Okay. So VSDs can occur as an isolated heart defect, so just a VSD by itself or in combination with other congenital heart diseases. So for example, in TETRALOGY, we know there's a VSD associated, and in TGA, their survival may be dependent on a VSD. So it occurs when the septum fails to fuse properly during embryonic development, and it's the most common congenital heart disease, and it's associated with some of the risk factors I've listed there. So particularly with the different trisomies, as well as some torch infections. So it classically presents with failure to thrive, as we saw in that question. So these children can present with recurrent chest infections, tachypnea, poor feeding, and potentially some other symptoms of cardiac failure. So smaller murmurs are often asymptomatic, but there's a paradox I'm sure you guys have heard of that. So the paradox is that smaller murmurs are actually louder than larger murmurs. So patients with a very large VSD will likely have more severe symptoms, but on auscultation, they will often have a softer or even absent pansystolic murmur. There won't be a murmur in the first place. So as you know, I'm a big fan of stupid mnemonics. So I got most of these actually from the Humorous Hacks podcast on congenital heart disease. So if you want more, I would suggest listening to it. It really helped me remember them for fourth year. So the one they had for VSD was VSD sounds like versus dinner. And that makes you think of MasterChef and people cooking food where they use pan. So it's a pansystolic murmur. It is really stupid, but it helped me remember it. So I just thought I'd include it. So VSD versus dinner, pan, so pansystolic murmur. And most of these VSDs, or most small VSDs, will actually close spontaneously. And they can be managed just with a high calorie diet to support their growth and to make sure they're tracking well. And they can also have heart failure medications depending on their symptoms. But larger VSDs with complications and signs of, like if they have more cardiac failure symptoms as well as Eisenmenger syndrome, which we'll talk about in a second, they will require like a surgical patch closure. So in congenital heart diseases with a left to right shunt, Eisenmenger syndrome is a possible complication for any cyanotic heart disease. So we're just discussing it in relation to VSDs, but just keep in mind that this syndrome can occur with any acyanotic or left to right shunt heart disease. So it occurs when there's prolonged pulmonary hypertension due to an increased left to right shunt. So because of this, the right ventricle has to undergo hypertrophy to compensate, and eventually right ventricular pressure slowly increases over time. And eventually it can also exceed the pressure in the left ventricle. So this will cause a reversal of the pressure gradient. And now these patients actually have a right to left shunt that will cause cyanosis. So depending on the severity, this can just be on exertion or at rest. And if this complication has occurred, it's quite a poor prognostic sign and indicates like that the congenital heart disease that they have is quite severe and they will need more advanced management. I've just got a question in the chat what the name of the podcast is. It's Humorous Hacks, and I think it's just their podcast on congenital heart disease. Highly recommend. Cool, so we'll move on to our next multiple choice question. So we have a 19-year-old female who's found to have left hemiparesis following a deep vein thrombosis. On auscultation, a fixed, widely split S2 is heard. I'll let you guys think about that. Okay, give everyone a moment. Okay, cool. So what we've got mostly is a bunch of B's in the chat, which is correct. So this is an ASD. It is a bit of a tricky one. Sorry, this isn't a child I put in the question. Technically, this is an adult, but congenital heart diseases can still present in adulthood if they were missed earlier on. So this is particularly seen with ASDs, as they can be asymptomatic and missed until later in life, unlike cyanotic heart diseases, for example, which are definitely picked up earlier in life due to the symptoms and the fact that they're hypoxic. So what leads us in this question to thinking about ASD is the fact that she has had left hemiparesis. So in this case, we're thinking, does anyone know, if we can chuck it in the chat, what we're thinking about, or like the term for this when there's this? That's fine. I think it's too complicated. All right. So, oh, amazing. People could read my mind before I even asked the question. Yeah. So this is a paradoxical embolism, which is classically seen with ASD because of instead of causing a pulmonary embolism with a DVT, because of that shunt or that ability for it to travel to the left heart, this is actually the DVT is actually caused a stroke because of this hole within the two atria. The other buzzword we see is the fixed widely split S2, and we'll talk about that as well now. Okay, so ASDs are the second most common congenital heart disease, and they can be associated with Down syndrome as well as fetal alcohol syndrome. So AVSD, so atrioventricular septal defects, are also associated with Down syndrome, and it's not specifically on the matrix, but it does sometimes come up on exams. So Down syndrome is a risk factor for a lot of these congenital heart diseases, but just keep in mind that AVSD is one of the strongest associations with Down syndrome. So just know that as a really big buzzword as well. So there are two different subtypes of ASDs. The more common one involves the foramen ovale, and it's due to issues with the septum secundum development. And the second one is the ostium primum defects, and they're less common, but they can present earlier in life, and they're usually associated with some of the syndromes that we mentioned. So most defects are asymptomatic and are picked up incidentally. So some cases, I've heard of some cases where people are just going for like routine employment screening in adulthood, and on cardiac exam, they found out they hadn't had an ASD. So they've gone their whole life without realizing. Maybe they've had some slight symptoms as a kid, but it can go unnoticed, as was the case in the multiple choice question we did. But if the defect is really large, they will present with the usual failure to thrive, chest infection sort of picture, and it can be picked up earlier in life. So on auscultation, what is heard is a soft ejection systolic murmur, best heard at the left upper sternal edge, as well as a fixed widely split S2. That's a really big buzzword, and that's due to the right ventricular stroke volume being equal in inspiration and expiration. So if you're having trouble remembering the buzzwords for it, there is more from the podcast. I won't be explaining this one on here, but I've included it there if anyone's interested, so have a listen if you are. So some ASDs will close spontaneously, but others will require surgical closure to prevent complications later in life. So that includes arrhythmias as well as the risk of paradoxical embolisms. So although it is a left to right shunt, and you'd think that not much blood would flow from the right to left, there is a small amount of blood from the IVC that may flow directly into the left atrium, so it bypass the pulmonary circulation. And that means a clot, for example, in the case of the question, can enter the systemic circulation and enter the brain, unfortunately. Okay, so we'll move on to our next multiple choice question. So we have a 10-day-old baby born at 27 weeks with worsening ventilatory requirements and no evidence of respiratory infection. The baby has a bounding peripheral pulse. Okay, so I've just got a question to repeat why there is a fixed widely split S2. So that's due to right ventricular stroke volume being equal in inspiration and expiration. The physiology can be confusing as well, but the Paeds faculty is quite nice. They love to just ask about the buzzwords. So it is important, it is good to understand like why it sounds the way it does. So definitely do a bit more reading if you're more interested in that as well. But it's just with the right ventricular stroke volume and the difference between inspiration and expiration. And in this case, there isn't a great difference. So, okay. sorry, I've got a couple of questions about VSDs as well. So why do they present after the first couple of months? So I guess the reason is as well is they're not a cyanotic heart disease. So usually in the first few months of life, things that are picked up really early are those that present with hypoxia and the baby's cyanotic, and that can be picked up really early. And with VSDs, depending on the severity, they could potentially present earlier in life. If it's a really large VSD, the baby could present at a younger age with symptoms of heart failure. In that particular case, it probably was a medium-sized VSD and the symptoms presented a few months into life. So I think it is largely dependent on the size of the VSDs and how soon that will regress into symptoms of heart failure. Okay, we'll answer this question now. So everyone's mostly had the same answer. So we've got K as the most common answer, which is correct. I've had a few other options sprinkled in there, but we'll talk about why this is a patent ductus arteriosus. So it is a bit confusing because this is a 10-day-old baby, and we did talk about how the ductus arteriosus usually closes within like day 1 to 2 of life, or within the first few hours of life. But it's important to keep in mind this baby was born at 27 weeks, so it's a really premature baby. So physiologically, it's a bit behind. It's like other babies that are born at term. So the ductus arteriosus, I guess, isn't closing at the time that you would expect for a baby that was born at term. So another reason we're thinking about PDA is the bounding peripheral pulses. So that's quite a classic like physical finding with PDAs, and I can give you a mnemonic to remember that too. It's also very stupid. Okay, so the failure of the ductus arteriosus to close postnatally is often seen in premature infants, as we talked about, just because they're physiologically, they haven't hit those same milestones before they were born. And it's also seen with maternal prostaglandin administration as well. So for example, stuff that's given with labor induction, which does make sense, as we normally give prostaglandins to keep the duct open in some congenital heart diseases. So if the mum was given prostaglandins, it can keep the duct open unnecessarily, and babies can present this way. So most occur in isolation without any other defects, and it has very specific auscultation findings. So with the machine-like murmur, heard loudest in the infraclavicular region. So back again with the mnemonic. So PDA can also stand for public displays of affection. So the way people will remember it sometimes is that like the couple is bounding and running towards each other, and I don't know, PDA in the left infraclavicular region. I don't know, we can't really unsee this buzzword once you think of it this way, but just thinking about how most other murmurs aren't really heard loudest in the left infraclavicular region. So it is quite indicative that it is PDA, as well as that machinery-like murmur is quite commonly seen. So PDAs may require closure if they're symptomatic, and premature babies are commonly given NSAIDs such as indomethacin or ibuprofen to help close it pharmacologically, and it can also be closed surgically. So as we mentioned earlier, ductal-dependent congenital heart diseases need PDAs to survive. So in that case, we would opt to keep the duct open by giving them prostaglandins. So I've included a table here. There's quite a few congenital heart diseases that can be dependent on PDAs for survival. So thinking about the main one we've talked about so far is transposition of the great arteries, and also sometimes tetralogy of FALLOT as well, because it can help to allow for mixing of blood in these cyanotic heart diseases. Okay. All right, we'll move on to the next multiple choice question. So we have a 3-month-old baby that has normal radial pulses, but her femoral pulses are very faint on palpation. Okay, cool. Okay, so I think we'll move on now. So yeah, we've got a lot of D's in the chat, and that's right, this is coarctation of the aorta. So there's not much information in this question, but I guess the biggest thing is the fact that this baby's femoral pulses are fainter than the radial pulses. So this indicates that along the way, there's something that's restricting blood flow to the lower extremities. So we'll have a diagram here to discuss that now. And sorry, I think the chat's getting mixed. There's a lot of multiple choice answers. So I'll have a read of the chat later. I think I've missed some questions, but I'll reply to them in a moment. Okay, so the coarctation of the aorta is the narrowing of the aorta at the isthmus, so the distal part of the aortic arch close to the ductus arteriosus and the left subclavian artery. So coarctation of the aorta can also be PDA dependent, and that makes sense as it's near the PDA. Sorry, it's near the ductus arteriosus. So if that's open, that can help redirect blood flow, and they can present less symptomatic. So if it's a mild coarctation or if there's a PDA present, it can mostly be asymptomatic. But if it's very severe, the baby will present with really weak femoral pulses, radiofemoral delay, lower limb claudication, cold feet, and lower blood pressure in the legs in comparison to the arms. So if untreated and it persists into adulthood, it'll present with persistent hypertension, and that can lead to various complications, so aortic dissections, valvular heart disease, and quite a few others. So prostaglandins can be given to keep the ductus arteriosus open, and depending on the severity, a stent can be placed, or they will need surgical correction to fix the defect, depending on how severe the coarctation is. Okay. So we'll move on to the next one. So there's an otherwise well young girl presents during a acute viral infection. On auscultation, a soft murmur is heard that varies with posture. Yeah, we'll give everyone a couple more seconds. Okay, got a few different answers for this one. So we'll talk about it now. The most common answer still was I, and that's correct. This is an innocent murmur. So there are a few ways buzzwords in this question stem that help us realize that this is an innocent murmur. So firstly, this is an otherwise well young child. So usually, I guess in most congenital heart diseases, there is some component of failure to thrive or hypoxia, they're presenting with TET spells, things like that. So this is a very well child, no other symptoms at all, and they're presenting during an acute viral infection. So this can be a time where innocent murmurs or just flow murmurs are heard more loudly, just because there's increase, like cardiac output requirements during like an acute illness, and that can accentuate the flow murmur. So that's why that's a buzzword as well. And with the auscultation findings, we'll go through I have a slide here, we can go through the different characteristics of an innocent murmur, but usually it's one that changes with posture or breathing, and it's usually quite soft and not a very harsh murmur. So these are the 7 S's in that blue table that describe the key features that we've talked about. It's good to know as it helps, I guess, in practice as well. It's one that you need to know what's normal and versus what's pathological. So most importantly, we talked about they change with position and respiration. They're usually systolic murmurs, and they are soft and have sort of a vibratory or musical sounding component. They're generally asymptomatic. The child is very well and usually presents when they're sick due to that increased cardiac output that accentuates the flow murmur. I've also included a table from a past Muppets revision lecture that really helped me summarize all the different murmurs and their buzzwords. So that can be helpful to look at for reference after the presentation. Okay, so we'll move on now to another question. So there's a 3-year-old girl who presents with a 5-day history of fever with a red rash on her legs. She has become more unwell with temperatures up to 40 degrees, worsening conjunctival injection, erythematous lips, and cervical lymphadenopathy. What is the most appropriate management? Yeah, so I've got a few different, okay, amazing. Everyone said D in the chat, which is very correct. And I was going to ask, does anyone know what the diagnosis is? Someone's already mentioned it in the chat. Does anyone know what the diagnosis is? Amazing. Okay, so this is Kawasaki disease. So the reason we know this is there are some buzzwords in the question that meet the diagnostic criteria for Kawasaki. So firstly, she's had a 5-day history of fever. She's got a rash on her legs. really high fever temperatures, so up to 40 degrees. She's got conjunctival injection, so redness, as well as that classic red and cracked lips, or we can assume cracked, and cervical lymphadenopathy. So a lot of these, the multiple choice questions, a lot of them were just quite random management plans, but D is the classic and what is needed for every kid that presents with Kawasaki's. So we'll talk about that now. So that little girl had very classic signs of Kawasaki's disease. So that's a medium vessel vasculitis of unknown etiology that almost exclusively affects young kids. So the diagnostic criteria of Kawasaki's is you have to have a fever of 5 days, and 4 out of the 5 criteria, at least 4 out of the 5 criteria listed here. There are many mnemonics, but I find warm cream the easiest one to remember. So if you've seen patients with Kawasaki's on placement, you'll know that these children are very irritable, very upset, and they often present with non-purulent conjunctivitis, a truncal rash, and their fingers and hands can get very edematous, and they have that classic peeling rash a few days into the disease that can be seen. They often have palpable cervical lymph nodes, and the classic strawberry tongue and cracked lips are shown in the photo marked B that can be seen. So this needs to urgently be treated due to the risk of coronary artery aneurysm. So you need to give IVIG stat as well as high dose oral aspirin. So normally we don't give children aspirin due to the risk of life-threatening Rey syndrome. That's a potential complication, but that's why we have to be really careful about how much we administer in Kawasaki's, just because there still is that risk of Rey syndrome. So patients will require echo at the time of presentation, and at 6 weeks follow-up to monitor for any aneurysm development, which is most likely to develop 2 to 3 weeks after symptoms start. So if they do have aneurysms, which is very rare these days, thanks to this just more awareness for Kawasaki's disease and earlier identification of it, the quick administration of IVIG. Sorry, one second. Yeah, so if they do, develop aneurysms, that can place them at a lifelong risk for MIs as well as other cardiac complications, but usually that's quite rare because hopefully we've given enough of the kids IVIG. I've just got a question about what H is in this list of this different photos of Kawasaki's disease. So that's just thinking about with the polymorphous rash that can occur, as well as you can see there's some desquamation as well and peeling of that perianal region. So that's something that could be seen as well. Okay, so we'll move on to the next question now. So we have a 14-year-old girl who presents with fever, intermittently sore knees, ankles, and elbows over the previous 4 weeks. She has a rash consisting of pink to red non-pruritic macules on her trunk and legs, and auscultation, she has a pansystolic murmur consistent with mitral regurgitation. And she has previous group A strep infection. So give everyone a second to think about that one. It's kind of obvious, like it's the only one that's on one of the only ones that's on the cardio matrix. Good. Okay, so this is rheumatic fever, and someone's mentioned Jones criteria, which is very important. We'll discuss that. And she does seem to be meeting some of that criteria. So she has a fever and she has sore knees, so evidence of arthralgia. She has a rash on her body, as well as evidence of previous group A strep infection, and has a pansystolic murmur. So the mitral valve is commonly most affected with rheumatic heart disease. So that's something important to know as well. So we'll go through the criteria now. So we'll quickly talk about it. I know it was on the year 3 matrix, so I won't go into it into heaps of detail, but basically rheumatic fever is a result of the body's abnormal immune response to group A beta hemolytic strep. So there are certain populations that are more susceptible to rheumatic fever. So some people have genetic susceptibility, so it runs in certain families, or they're just more susceptible themselves, but it's also more commonly seen in malnourished populations and those living in poverty. So in order to be diagnosed with rheumatic fever, you need a positive threat culture or elevated anti-streptolizin titers, and either 2 of the major Jones criteria or 1 major and 2 minor criteria. So you can just go through it there. So there's the Jones criteria that includes arthralgias, myocarditis, like the subcutaneous nodules they get, erythema marginatum, which is that classic migratory rash, as well as synonyms chorea, that dancing, typical chorea, which is very pathognomonic for rheumatic fever. So rheumatic fever needs to be treated with IV antibiotics, analgesia for the arthralgias, and there's a high risk of rheumatic heart disease if it's not treated properly, and it can require prophylactic antibiotics for many years after the initial illness. So depending on the severity of the initial presentation of rheumatic fever and the extent of rheumatic heart disease they may have. So they could be on antibiotics till they're 40 if they've had very severe rheumatic heart disease complications, or for longer, depending on when they present. Okay, so we'll quickly finish up with infective endocarditis. So in pediatrics, we're mainly thinking of kids that have congenital heart diseases, previous rheumatic heart disease, and previous cardiac surgery. So they're the kids in the biggest risk factors for infective endocarditis. And we're thinking about similar organisms that we do with adults. So strep viridans is more common in kids with congenital heart disease, but we also do see Staph aureus as well. So these kids will be encouraged to maintain really good dental hygiene, as that's a big risk factor for IE in their demographic. So dental procedures are really high risk, and we want to avoid these kids even needing dental procedures in the first place. So if you've ever been to like a Paeds cardio clinic, like they really just hammer in the importance of like, you got to make sure the kid's brushing their teeth, making sure that everything's clean, because they just can't afford any dental complications. It's just not worth the risk. So any child that presents with the fever and a new murmur should have infective endocarditis considered as a diagnosis. So looking for the signs we have listed here, so presenting after the fever, as we said, myalgias, headaches, and physical signs that we know, such as Janeway lesions, splinter hemorrhages, or thinking about microemboli from the infected valve. So it's treated with IV antibiotics, and if there's an infected prostatic valve or something that's infected within the heart, like any other material from previous cardiac surgery, that would need to be removed because it's the source of the infection. And as we mentioned, most of these kids with congenital heart diseases or prosthetic valves will need antibiotic prophylaxis for dental procedures, because of their risk. So I think that's about time as well. So I've just finished up there as well. I'm not sure how much time we have for questions. You can pop them in the chat, or if you want, you can email me later and we'll include it all in the Google Doc later. Or if it's on the Slido, we'll answer them at some time. Liv, do we have any time to continue? I can see if there's any questions in the chat to answer.
Yeah, you probably have, you can spend another couple of minutes if you like answering questions. There's a couple in Slido.
Okay.
I can read them out if you want.
Yeah, sure.
Do you do the hyperoxia test for transposition as well, or is that just for tetralogy?
It's for transposition as well. So any baby presenting in that neonatal period with hypoxia, it's a really quick way to differentiate if it's a cardiac versus pulmonary cause. So with that baby that presented at 2 days old with that worsening like hypoxia, they could easily do a hypoxia test because it only takes 10 minutes. So that's commonly done for most neonates that present that way.
Cool. And someone's just asking about what was the paradox of VSD? They were, I think, asking, maybe you mentioned it. Yeah.
I'll get the slide up as well. So that paradox was just with the sound of the murmur in relation to the size of the actual defect. So smaller VSDs have better prognosis just because they are small and they'll cause less symptoms. But on auscultation, they'll be louder just because there's more flow going through a smaller defect within the ventricular septum. So they'll sound much louder, but in reality, they're less severe and we have to be less worried about them. But a baby with a really large VSD could have a more silent murmur, but actually we're more concerned about them because they can deteriorate quicker just because they have a larger VSD. So that's the paradox. It's just the size and the sound of the murmur.
I'll just ask one more question.
Sure.
For all congenital heart diseases in an OSCE, would you order an ECG, echo, and chest X-ray for all of them in general?
I guess if you're just listing all the possible investigations you would do, I think that's fair to say because you're trying to think about all the possible, whether it's cardiac versus pulmonary, if you're thinking about congenital heart diseases. I think what's more commonly done, depending on the age of the child when they present, so chest X-rays are commonly done. ECGs can be normal, but they can show right ventricular hypertrophy. So it depends what congenital heart disease you're thinking about. But for all of them, echo usually is the mainstay of diagnosis. So that is the way it's like officially diagnosed, because they've visualized the defect using echo. So I think that's really fair to say you would do a chest x-ray, echo, and an ECG possibly, because that's quite a non-invasive test to do.
Awesome. I think we'll probably leave it there, but there should be a few other questions that we can answer later on.
Okay, sounds good. Thanks, guys.
Thanks so much, Anisha. That was awesome.